Hello and welcome to another bite-sized educational video from Spear Medical. I'm Eric. Today I'm going to be talking to you just briefly about end-tidal CO2 measurement or invasive end-tidal CO2 measurement in our patients. So what do I mean by end-tidal CO2? We're talking about the device that we attach either onto an endotracheal tube or a supraglottic airway device such as an iGel. Now these devices then will attach to a monitor of some kind, either a large sort of combination monitor with a defibrillator such as a core pulse or a life pack or a ZOL, or it might actually be a standalone device such as EMA. Either way, it'll take the measurement in one of two ways. It'll either suck some of the air out of your airway sort of setup and sample it with a sort of measurement device, or it'll use an infrared sensor to measure CO2 in your airway circuit. So, like I said, we're just going through the basics here really today. A few things that I'd like to point out to get started. We in the UK, I know, well, at the very least in the UK, we measure the numerical value of end-tidal CO2 as kilopascals, and the normal range that we're looking for is 4.0 to 5.7 kilopascals in a patient with an advanced airway in place. I know some other systems around the country use millimeters of mercury instead, in which case you're looking for a 35 to 45 millimeters of mercury sort of measure reading to be considered normal. Now, the literature does vary a little bit on these figures. This is the sort of best consensus that I could find, but there are some slight variations, but nothing too drastic in the literature out there. But why do we actually care about end-tidal CO2 monitoring? There's lots and lots of reasons why, but some of the ones relevant to pre-hospital emergency practice, so for paramedics and sort of pre-hospital doctors, is first of all we know that if we manage it well, if we maintain these normal ranges, we actually improve the outcomes of patients suffering with a traumatic brain injury. We know that in cardiac arrest, it gives us one of the earliest indications that we've got return of spontaneous circulation, so ROSC, so our patients responded to our resuscitation and we've got them back. It also allows us to understand whether our CPR is effective or not. And on a sort of sadder note, it also serves as a prognostic tool to help us make futility decisions when managing a cardiac arrest. So we've had a consistently low end-tidal CO2 for the duration of the arrest, and that suggests that actually, obviously combined with other factors, that we're probably getting to the point now where we need to recognise life extinct. So it's a really useful tool, and if managed correctly, can improve outcomes for our patients. We know what the normal ranges are now that we're looking for, the little numbers on your monitor. We'll have a quick look at just some of the waveforms that you might see. So certainly if you're using a monitor like a life pack or a core pulse, as well as getting these numbers, you'll also get a waveform picture. And these can tell us a little bit of a story. So your normal sort of picture we're looking for is this. And this is just telling us a bit of a story about the way that the patient's breathing, or the way that we're ventilating the patients, and the efficacy of that really. So we're looking for a nice equal sort of distance, just like an ECG really. So we're looking for symmetry. We're looking for that good distance between each of these little sort of top hat pictures. And each one of these represents the ventilation of a patient. So if they're breathing spontaneously, it's the breath in and out, or if we're ventilating them, it's telling us the way that we are ventilating them, and the sort of the efficacy of that really. You might see a slight variation to this, and this is particular in the cardiac arrest, or if you're managing a ventilated patient following something like an RSI, and you might just get a slight notch in the picture like this. And actually what this means is the patient's trying to take a breath. So in the either sedated patient or the patient in cardiac arrest that we're ventilating, What this little notch could signify is that they're attempting to take a breath whilst being ventilated. And again, that can be a really, really early sign of either the sedative, the muscle relaxant that we're using wearing off in a sedated patient, or in cardiac arrest, that actually the patient's attempting to breathe for themselves. A couple of things that can help. We can actually diagnose some problems from end-tidal CO2 capnography. So if we were to get sort of something that looks a little bit like this immediately following intubation of a patient, that could actually tell us that we've inadvertently intubated the patient's esophagus. So that would be an extubation followed by your sort of failed intubation drill there. And actually, when we talk about accidental esophageal intubation, amongst all the other tools that you'd use to identify that, capnography is generally quite a surefire way of identifying immediately that you've managed to intubate the esophagus rather than the trachea. So they're just a couple of the sort of tools that we can use waveform capnography for, which is this bit here that we've just been looking at. We know that our normal ranges, if we manage a patient to normal ranges, we can improve their outcomes. So actually, I've discussed normal ranges and the importance of needing to keep them there, but actually, how do we keep them there? That one's nice and straightforward, really. If they are hypercapnic, if their end-tidal CO2 is too high, then with our ventilation, we just need to increase our ventilation rate, so increase the amount of times that we're squeezing that bag, and that will actually cause the end-tidal CO2 to lower. And then the reverse is true for a patient with hypocapnia. So that's a patient with where the end-tidal CO2 has dropped below that 4.0 kilopascals consistently, and we need to try and get that up a little bit. So what we actually do there is just slow down our ventilation rate. So the end-tidal CO2 is low. We slow down our ventilation rate, and that causes a degree of CO2 retention and thus end-tidal CO2 to rise. So this was for your hypercapnia, and this is for your hypocapnia. And actually you find with these patients, often it's a balancing act between sort of bagging them too fast or too slow to maintain a normal range of end-tidal CO2 with them. So I'll just annotate this a little bit better for your reference. So green would be end-tidal CO2, and red is your ventilation rate in response to the end-tidal CO2, and obviously it's moving that way, so hopefully that helps. So that's it, whistle-stop tour of end-tidal CO2. I hope you found it helpful. If you did, just drop us a like on this video, and if you could subscribe to the channel, subscribe to the channel, that would be great. It helps us produce more content. And like I said, I hope you found this very basic introduction to end-tidal CO2 monitoring somewhat helpful. Thank you very much. Goodbye.